in the back. I think I have a mic on. Is it still okay if I'm like this?
Yep.
Okay, all right. And not too bad like this? All right. All right, I have transition lenses on. I thought they'd be better. Darn it, they're not. There's like this blur. There's a zone that's kind of okay, but oh, whatever. And looking down, the idea was that I could read my notes. This is my entire set of notes, which are how I'm going to coordinate with the morning. I need to also let you know that Pat and I go way back, and so when he called me and said, would you come out on your first week of class and teach people for me instead, I'm like, well, really? Okay, but I did, obviously. But he's busy. He's a very busy guy. So the original communication and what I was originally putting together and why I'm here speaking to you about, I thought, wheelchair seating and how to deal with seating and stuff like that. And the opposite is like, well, actually, it's kind of really about communication. I'm like, okay, all right. So we got to morph it a little bit. So the title is Troubleshooting Seating and Tips on Getting the Right Communication. And we're going to focus more on sort of the back half, the right wheelchair, via communicating, okay? And then I'll still catch up with some tips on some troubleshooting too, because that's a practical application. In terms of tying in to, oh, that's so perfect. Are you guys going to sit? Nobody? Front row, perfect, because I needed to volunteer for something, so that's great. That is perfect. So in terms of tying in a little bit to the morning, okay? So the last two people that got here, could you guys just stand up? The last two people. That's good. Okay, so and you don't have any there. So all right, Madison. So Madison, have you ever had sore shoulders? Yeah, and you say, could you rub my shoulders? Right? So your good friend here, we're going to ask Chelsea to give you a shoulder rub. Did you do that? Robert, give her a good shoulder. Okay, do you see where she's rubbing? You see that? All right, thank you. Sit down. All right, so this ties in to the very first guy Dr. Helm was talking about terminology. And you all thought he meant when you started talking science-y words that patients might not get you, okay? But when we talk about shoulder pain, right? People come in and they say, oh, I've got shoulder pain. Well, what you just rubbed is frequently what the person is talking about. They're not talking about the glenohumeral joint, but we immediately go there. We go, oh, impingement syndrome, they're using a wheelchair, okay? So that is a huge breakdown in little terminology that's not even terminology, it's just jargon and assumption, okay? So that's thing number one. And then I'll blend into Jane's a little bit too. She said she doesn't like confined to a wheelchair. Me neither. And I think that it's a brain set for yourself, okay? Not for the individual who's using the wheelchair, but for the clinician. If you're thinking confined to a wheelchair, you're setting up a whole dynamic with that individual who needs to use it that doesn't need to be there. You, particularly PTs and OTs, you need to think freed by the wheelchair, okay? Because if you're giving them the right equipment, they should be, in fact, more empowered, more enabled than they were without it, okay? Not in any kind of negative way. All right, so that was what I had not prepared. Okay, so what I have prepared is to start with figuring out how to get the wheelchair that you need, okay? Now, I'm going to run through a few things in the first few slides that are just kind of concepts. I'm going to circle back to them and blow them up a little bit, but I want to make sure that I hit them at least, okay? So here's the thing. Figuring out what wheelchair somebody needs, and usually the person who really needs to figure this out is the person who needs it, okay? Because again, as Dr. Helm said, the patient really knows. They know what they need and they know their body best, okay? But remember, acutely, that's not true, okay? So when somebody's brand new to a circumstance, in fact, in our neuro rehab world, people with adult-acquired neurologic disability, they do not know and they are not the best. And that is a dichotomy that you kind of have to work with a little bit because at that point everything is new and it's a little bit scary. Okay, but when you think about what wheelchair somebody needs, you need to answer the question, what does the wheelchair do? Okay? And it seems like, well, duh, you roll around in it. Well, no, that's not anywhere near enough of an answer, okay? You got to really think for the individual, what does that chair have to do? And for example, one example, if you're getting a brand new chair, okay, and you need to think about, say, caster sizes and rear wheel sizes, and it should matter where that chair is going to be used, okay? What environment will it be in? The size of those wheels will matter on where you're going to use it. Similarly, if you're in a power wheelchair, you got to think about things like ground clearance, okay? I learned this the hard way. By the way, how many of you guys are students mostly, right? How many students are? All right, but how many are not students? Okay, good. All right, so maybe you guys will learn something from me, but the students, realize this. This is one thing you get to learn from me. You will learn a whole lot by making mistakes if you pay attention to them once you're actually a professional, okay? So how do you learn that ground clearance is really important? You send somebody out with a chair that doesn't have very good ground clearance, who lives in a rural environment, who gets high-centered on the bottom of his chair, who's a C4 quad, and he's pretty much trying to rock with his head to get off of this stuck high-centered position, okay? And then the next time you do it better, okay? So we have to pay attention to the errors that we make, and that's one that I definitely made. Okay, all right. Postural support. Postural support is something that some people who use wheelchairs need. Not everybody needs it, okay? Not everybody needs all the whistles and bells on a wheelchair, and not everybody needs accessory seating. Hard wrapping seats and seat belts and straps. You don't necessarily need it, okay? But it's different than the duties of the chair. This is often a subset of the chair, an added part. Although I have told you, and I will tell you, that the configuration of the chair adds to the postural support. If you need it, you have to configure the chair for it, okay? But although not everybody needs postural support, nobody should ride a chair and be uncomfortable, okay? And that's part of our job too. That's part of our job, is to stop assuming that pain's okay. If people are not comfortable, or if they have musculoskeletal pain, our job is to have it not be there, okay? Musculoskeletal pain differentiated from neuro pain, okay, central pain. Neurogenic pain, we as OTs and PTs might not be able to help. Musculoskeletal pain is reproducible by us. We know how to do it, just orthopedic eval, and we should not let that be tolerated because we can fix it, we can intervene, okay? All right, when you do need postural support, it's mostly our neuro patients. It's going to be when the trunk and the neck do not have enough strength to hold up against gravity, okay? And that's often going to be people like spinal cord injury, okay? So you need to be thinking postural support, but even in the population of spinal cord injury, there's only a certain subpopulation that don't have a good innervated trunk, okay? And this is important again, because you go to a class and you learn about how to set up a wheelchair for a patient who's got paraplegia, and if you don't differentiate the high paraplegia who doesn't have trunk compared to the low who does have a fully innervated trunk, then you're setting the chair up wrong, okay? So again, our job is to not do these big blanket categories going, oh, here's the kind of chair that paras get. That's not okay, because it's based on the patient in front of you and what is their body able to do, okay? Super important. Now, some people, again, this is after they've been living with a neurological condition for a while, or maybe before they got injured. They might have some scoliosis, or they might have some postural deformity, or they might have some contractures, limited range of motion. If they can't get into a good alignment, you can't make them do that with a chair, okay? So if they can't get into a good alignment, you've got to accommodate it, and that's a different thing. Then your goal is best alignment, okay? Like the best for function. And sometimes that just means comfort. Oh, and the last thing under here, it says never, ever, ever use a wheelchair to stretch, okay? I don't know how many people have come back into my student clinic even, they're like, well, why do you have elevating leg rest? Well, I have tight hamstrings, and so the therapist wanted me to elevate my legs so that I wouldn't get tight hamstrings. It's like, ah! Because where do the hamstrings attach? Steve? No, I'm kidding. I met Steve at lunch. I told him I'd call on him. But where do the hamstrings attach? On the pelvis. Or the ischial tuberosity, right? And then they go down and they cross the knee, right? So if you have tight hamstrings and you elevate the footrest, what's going to happen to your pelvis? It's going to come sliding forward, okay? Force goes to the point of least resistance, okay? Memorize that little mantra. It's how the Grand Canyon was made. It will help you in all of your evaluation, right? If you have a short lack of range of motion someplace, you're going to push hypermobility to the point of least resistance, okay? So, never mind, I'll stay centered, okay. All right, skin protection. Only some people need skin protection, but nobody should be uncomfortable, okay? The people who need skin protection, where you need to actually think about a high-end skin protected cushion, have a lack of mobility, they have a problem with sensation, they probably have lack of circulation, they've got a skin nutrition issue, okay? Or they've already had a skin breakdown, all right? Then you need to be thinking kind of high-end skin protection. But for everybody, you don't need the top cushion. You don't need the cushion that the vendor might tell you is the latest and greatest one, okay? You need the level that the person in front of you needs, all right? Now, this is exactly it for my slide on insurance and how you're going to get this stuff paid for. This is it, okay? Because regionally, there's interpretation of national insurance, and then there's regional biases, and so I can't really come here from Washington State and tell you how you're going to get stuff through your insurance here in this state. But I will tell you that I've never had equipment denied. That's not true. I've gotten denial letters, but I've ultimately gotten every piece of equipment that I've sought for every single patient I've worked with, okay? And I stand here and people are going, what? That's not, well, partly because of this. I ask for things that are needed, okay? And I can make sure that the patient needs what I am getting for them. I do not pad with want, okay? If they just want it, and I sign that form, I'm probably going to get a denial, and once you get that first denial, you've slowed the whole process of getting equipment down. So I tell you, do a good job, ask for what's needed, and you then fight for it. So the comment that you need to be an advocate, yeah, you do need to be an advocate. And sometimes you need to take it up a level. So one particular patient who he had been spinal cord injured since he was 2 years old from a surgery on a tumor, a cervical tumor, and he'd been incomplete, and actually when I met the family was when he was starting to have a hard time. Dad was having a harder time carrying him. He was 9, and he was getting heavy enough that Dad was missing work with low back pain because he would carry his son whenever they were going longer distances, and the kid walked, but walked really poorly, wearing a TLSO and wearing bilateral AFOs, and he had contractures in his hip and everything else. So he walked with a very painful gait that looked something like that with the TLSO on, okay? So that's a clamshell body jacket. When I met them, they thought that they might want to get a wheelchair, but they weren't quite sure whether they wanted a wheelchair. And here's another piece about what people hear and know from their providers. This kiddo was sweating profusely and feeling flushed when he was sometimes doing these exertions, okay? Does anybody think they might wonder about that? What might they be thinking? Yeah, you might be thinking dysreflexia, right? The family had no idea, did not have a clue what I was talking about. They had never heard this because they thought they had a son with orthopedic issues because their son was only being followed by an orthopedic surgeon. So the first thing I did in advocating was get this guy into the right kind of care. Fast forward, then I got him an ultralight wheelchair, and he was being carried to school or driven. He only lived about a mile. As soon as I got him the ultralight wheelchair, he took himself to school, and he was in elementary school. He thought that was so cool. Then he ended up getting a paper route. I mean, so it was just huge. It was wheelchair free, right? It was wheelchair free. Fast forward, He's now a wheelchair athlete. He's in high school. He's playing basketball. He flips over, and unfortunately, he breaks his back. And he's now a real T7. Okay? So he had been incomplete. Now he's a full T7. He's been using a wheelchair for maybe 7 years. And I see him, well, a little bit less. But I see him again. And I put him for a new wheelchair. The chair's hardly changed at all because I'd gotten him a really nice one before. Chair's almost the same thing, a little bit bigger. But now I need a skin protective cushion. And it's denied. And I went ballistic, okay? I mean, I went absolutely ballistic. So there were letters to the paper. I called journalists. I called every legislator. It was approved the next day. So he got the cushion. So sometimes you have to take it off. I was just like, are you kidding me? Here we go. Okay, so anyhow, there we go. So how do you do this? How do you think about what equipment do people need? You need to be systematic, okay? And I made this chart a while ago, and the slides, like I said, are coming out to you. This is actually in a chapter in a textbook that is no longer in print. It's a Adele Field-Fote book. It's a chapter that myself and Kendra Betts wrote, and I sent a scanned copy of the chapter to Pat to stick up on the webpage and also to give to the students. So you'll have that as a resource if you want to go look at this. But basically, you start here. This is my box. What does the equipment need to do? What does the wheelchair need to do? And by the way, this works for a brace too, like a lower extremity orthotic or upper extremity orthotic, anything else. This is a way to think, okay? So what does the equipment need to do? How do you figure that out? Well, as a clinician, you do a physical exam. For seating, it's a postural eval, okay? For seating, it's going to be a postural eval. You do a physical exam and find out some information. And then the functional assessment is basically figuring out what's this person's life, okay? What are their social roles? What do they do? Where do they live? What do they want to do? Because that's how the functional needs are. Then you're going to figure out a list of equipment that meets those needs, all of the needs. You select what you want from there, you do trials, you get the equipment, and when the equipment comes in, you do a final fitting and you check, is it doing what I wanted it to do? So you circle back to, have you met your goals with this equipment, okay? And if not, you fix it. All right, so we're back to this question, what does the wheelchair need to do? Well, it starts with, why is it needed? Why do I need a wheelchair? Okay? Knee-jerk, probably I can't walk. But is that absolutely true? Maybe not. Because it might just be I can't walk far enough. Okay? So it might be more of an endurance issue. If I can't stand or walk at all, that sets up a different chair need than the person who can stand and walk a little. If I can stand and walk a little, my chair better be set up to make it easy for sit to stand. Right? But if I can't walk at all, it wants to be a different configuration because that one that's easier for sit to stand is going to probably be a bit bigger in footprint, which I don't need if I need to get around full time. The paralyzed trunk is when you get into postural support needs in your chair. Okay? And again, that pretty much starts when you lose your abdominal wall and the correlated muscles behind. Okay? But once you lose your abs, you need some postural support, and then the higher your loss is, the more postural support you might need, okay? So what you're basically doing is you're establishing the needs of the user, and that means the postural needs, and then that means the functional needs. Now the postural needs are determined by a physical exam, which is basically a postural eval, and sorry, if I don't recap this, I'll spill it. Usually that is now going to be an OT or PT who's going to do this postural evaluation, and I'll walk you through a little bit of it. I worked with the PT students the other day to walk through a little bit more, and I also know you have faculty in both programs that know about doing MAT evaluations and some of the foundational stuff that I could teach, but I don't have time to. Okay? So that's what a postural evaluation is. But what you're basically doing when you do this, when you figure out what the person in front of you has for assets and deficits, okay, you're figuring out how you have to build the chair. what configuration it needs to support their posture. All right, now functional needs is where the user, the chair rider, has to start talking, okay? And you need to start listening if you're a provider, because you don't know this stuff. So this is about basically these categories. How long are you in the chair? How much time do you spend in the chair? What environment will you be using it in? There's a question about wheelchair skills and ability. Now here also, that might be a place you can intervene. So you might recognize that somebody has some skill ability deficit, but you don't necessarily get a brand new chair or prescribe a chair to something that you can intervene at, right? So if there's a skill deficit, but you can teach the skill, then you don't get them marginal equipment. You don't get them the beginner kit just because you need to teach them, okay? So you can still shoot for where they ought to be functioning. And then self-care. Self-care matters lots. Let's blow this up. All right, so transferring. If a person can transfer easily and independently, that means they're going to get out of their chair. This person will get out of their chair to drive. They're going to sit in the driver's seat. This person's going to get out of their chair in a movie theater. They're going to sit in the theater seat. They're going to get out of their chair, maybe on the couch to read. Okay, they're going to get in and out of their chair a lot. So it's going to tie into time in chair, and it also ties into how you set up that chair. If, on the other hand, they're a max assist caregiver needing help or maybe a hoist transfer, they're probably in it for the duration of their uptime. They're probably going to get in once and then get out at the end of the day. And that chair needs to be different, okay? It needs things like maybe armrests to add some support. It also needs to be designed to recognize caregivers are helping, okay? If caregivers have to help, you've got to think about what the caregiver needs, how easy it is or isn't to get in to reach and adjust the pelvis or help somebody with their bladder management, okay? So this is, again, the time in the chair. So part of it ties into transfers, okay? But it also is it's also mentality and what they want to do, okay? Some people may not be up for all day. Some people may not get up until midday. Some people may get up and be in their chair for 16 hours, okay? And again, I already said this, but if they're going to be in it the whole time, you need to think about things like armrests that you might not put on a chair that's just a mobility device, things like pressure relief, and maybe even positional changes if they're going to be in it all day. All right, terrain covered. So this is sort of my environment side. So where are they going to be? Okay, so where are they going to be? If you're going to be indoor level, right? Indoor, just a linoleum floor. Who's that? That's your nursing home person, right? That is somebody who I will work to get. This is your little old lady. Somebody who's weak, but is only going to push the chair on indoor level surfaces. They need the best, the least roll resistance. They need the easiest to turn casters. So that might be the person who needs the little rollerblade casters and the high pressure tires, because they're working in the environment that those work best. But if you're going to take that same person and push them across carpeting, forget it, okay, or grass, okay? So you have to think, where's the environment? But on the other hand, if you have somebody who will go out in the community, they might need some shock absorption, or they might need larger casters to traverse terrain, okay? You also have to think about durability. How many times are they going to jump off a curb? Are they going to jump off curbs, or are they going to go down 2 or 3 steps every day? Because then the chair has to be built different, okay? If it's a power chair, not only do you have to think about that ground clearance, but battery life and endurance and durability of the chair. And we don't know any of these things unless we ask, okay? This is, where do you live? What does it look like? Do you have a paved driveway, or is it gravel, okay? Those are the questions that you have to find out in terms of what these chairs need to be. All right, this is the one where I said we can teach these skills. So does the person know how to do wheelies? Somebody who can do really easy wheelies can have microcasters, because because they never push them in the carpet or on the grass, because they're just going to lift them up, and they're going to push on the rear wheels across any terrain that's difficult, okay? But if you have really marginal wheelchair skills, then you need to be on a wheel that will take care of some of the terrain for you, so a little larger diameter caster kind of thing, right? Okay, now self-care. How much ADL is happening in the chair? Are they going to get dressed in the chair? Are they going to change their shirts in the chair? In particular, bladder management, okay? So, do they have external catheter in a leg bag? Are they going to need to drain that leg bag? How do they do that? Are they going to do intermittent catheterization, which is passing a catheter into the urethra? If they're going to do that, they need to be able to access, and therefore they're going to have to be able to move forward on the seat. How are they going to be stable? Okay? If they are somebody who doesn't have neurogenic bladder and can urinate on their own and are going to pee into a urinal, the container thing, how are they going to do that in the chair and not end up with a mess? Okay? So you have to think that thing through. And if they're using a Foley catheter and you're putting them into some of these really tucked positions, some people won't drain. Okay, so if you have an indwelling system, sometimes you have to be able to open the hip and extend the hip in order to get the tubing system to drain. So those are things you have to think about, and you can't, and cathing is super important. Bladder management is very, very important, okay? You can't say that's the nurse's job, OT does dressing, I just am setting up a wheelchair. No, 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 no. If you don't either collaborate together or you just take it on for your own self, that you get to cross over domains a little bit, because otherwise the chair is going to be wrong. If they're getting dressed in the chair and you've decided, and they've used a chair for a number of years, and they've come into you and you've decided their posture's not very good, and you're going to improve it by putting a nice solid backrest on. But it turns out they dressed in the chair and they also need to cath in the chair. You've just destroyed their ability to do that because you didn't check how they do that maneuver, and frequently it's leaning back over the top of a softer backrest, and so now you've just destroyed function, okay? We are not about ruining function, right? We're about figuring out how to enhance it. So you have to ask these questions and make sure that you know not only what the chair has to do, but what the person does in the chair, okay? All right, where is the chair going to be besides under the person? So if you're driving a vehicle, where are they going to put it? Okay? Vehicles are a lot more expensive than wheelchairs. Wheelchairs are expensive, okay? But even a power wheelchair, which is really expensive, if you have a van that's lift equipped and adapted to drive, it's more expensive than your wheelchair, okay? If you have a manual wheelchair and you're driving a regular car, the car's more expensive than your wheelchair. So you have to work with the idea of what car do you have, what car do you want to have, where do you put your chair, and will this new one that I'm thinking of fit? When ultralights came out into the world, a whole bunch of people used to stow their wheelchairs behind the driver's seat, sometimes behind their passenger seat, but that was when cars still had bench front seats and no airbags and all kinds of other stuff. But anyway, so they'd come in and they would pull chairs, a folded chair in behind the seat. You could roll it right in, there was room, okay? Ultralight wheelchairs, on average, fold 5 inches wider than the old chairs used to. So anybody came in and you're like, oh, I'm a hero, I'm getting you an ultralight wheelchair. And then they get it and they go out to leave, and they can't leave because they can't put it in their car. Now, quick release wheels made it so the chair will eventually fit, but now you've got somebody who you've got to teach a new skill set to, a new way to put the chair in the car, and most of the time they're like, what? Right? So you have to think these things through. A fellow right now that I'm working with for a chair drives a Corvette and wanted the new C7 and was waiting to, his chair fit just barely in the back of his Corvette, and he was waiting for the new C7. No way he can get a new chair. Casters are falling off. Gotta wait because I need to make sure that the chair will fit in the car because I'm buying this car. Okay, so again, you have to think these things through. Okay? If there are going to be a passenger in the chair, So if they're gonna ride on public transportation or tied down in of their own van even, then the chair has to be a little different, okay? It has to have a higher back, and it shouldn't be bolted on by you. I want you to remember that the safest place for anybody to drive is in a vehicle seat, okay? Which means if you're a physical therapist or an occupational therapist who works with people who drive adaptive equipment, your highest priority should be car transfers, okay? It is really easy. One of the easiest transfers in the world to teach is a transfer to a six-way seat in a van. So the six-way seat in a van is a van seat, the driver's seat, that goes forward, back, up, down, and spins, okay? So if an individual is going to be able to do an independent transfer anywhere, they're going to be able to do that one because it's a short sitting transfer only. That means I don't have to manage legs. I can get it dead even to my seat, and I can lean on stuff if I need to, even if I don't have a good balance. So if you do nothing else, and that's weird, right? What? Are you telling me the first transfer I should teach is a vehicle transfer? If you have the equipment to do it, yeah, it's more important than a bed transfer because it's light. Somebody can get in and out of a van and move around. It's huge. Once you've given them that, they'll do it a lot, and then everything else starts to become easier, okay? But at any rate, you need to know if they're going to be in the wheelchair, that I'm telling you it's not very safe, but sometimes it's the only way to go, and so you need to make it as safe as possible by making sure you've got higher backrest, headrest, and things like that so that they can be safe in that vehicle. All right, maintenance and repair matters, and I get it. I'm at the Rural Rehab something or other network. So anyway, I know rural is in the title, okay? So that means you do have an issue with this, okay? So you can't send people out to some place where they can't get service with high-pollutant equipment. And even the manual wheelchairs, if you can't get a part for something fancy on it, you basically have a broken, you have no mobility. So you have to make sure that people know where they can get parts and service. And also, you know, it's kind of a generational thing. My PT students, I'm going to just do this instead. How many people know how to, by yourself, change a bicycle tire? All right, now I want you to take a look around the room for a minute. Hands up, change a bicycle tire. All right, so now it's a problem, right? So A, either you're not riding enough bicycles or you're really, paying too much money to have your tires repaired. But so you have to know how to do this because you really ought to teach patients how to change wheelchair tires because it's the same thing. You just work on the side that doesn't have a hand rim. And if you don't know how to do that, they don't know how to do that. And you're sending people out asking them for problems, okay? So just some of these things are just, life skills that somehow got evaporated. All right, I don't know how to program a remote control to do my TV. Okay, admitted. So there's some things that I don't have either. Okay. All right, so again, I'm saying this is how we think about equipment, but there's still all of this. You still have to do all the medical stuff, right? So you still need to look at the chart. You need to find out whether they got cognitive abilities and all this other stuff. So that's important too, and that's going to influence what you're doing. Bottom line is what we've done so far is we've figured out what the chair has to do for the rider, okay? And we come up with that list. We're like on the second step on my chart, okay? Now what I'm going to tell you to do is think simple before complex. And that's even more important in rural environments. But anything you add to a wheelchair adds the possibility of breakage, okay? Any new actuator you add to a power chair adds height, and height in a wheelchair is a problem, okay? Because it means getting under tables becomes harder, it means getting into a van becomes harder, it means all kinds of problems. So don't add things that you don't need. Think simple before complex. And part of the reason that I say that is because anybody who's marketing equipment is going to tell you the opposite, okay? And I need to remind you, they're not mean, they're not vicious, they're not malicious, but they're in business. They're in marketing. Their job is to sell the equipment, okay? And so they're obviously going to tell you that you need it. Your job as a clinician is to know what the patient in fact needs and only get what you need, and don't add too much. Okay, here's where I get to say posture matters, and I'm going to tie back into Jane's conversation about communication and assumptions about what people can do and whatnot, okay? And again, nonverbal communication is something that generationally we're losing, and if you don't believe it, go look, just Google New York Times facial recognition test, okay? And what it does is it shows you a bunch of people giving facial expressions, and you get to see whether or not you can read it. And the millennials, which unfortunately some of y'all, can't do that very well. So what that means is, because of changes in technology and how we live, we're losing some of our ability to pick up nonverbal communication, which is not good if you're a healthcare provider, okay? But where I started was posture matters, right? Posture shows you something. I'm feeling pretty confident, right? No, I'm kind of not, right? I mean, I can make it a little bit, but if I'm giving you a posture that you're reading and you're perceiving as a communication, but I don't intend it because it's the posture forced on me by my wheelchair, then my communication is I'm giving out the wrong message, unintentionally, okay? And so that's something to think about when we think about how important posture is, and that we can make a difference by doing seating right, okay? So, for anybody who's using a wheelchair, if you have not been out of the wheelchair for an evaluation, you have not had sufficient evaluation. And here's my message to you. Don't let anybody buy you a new chair, prescribe you a chair, etc., without you having gotten out and having a full lower body passive range of motion evaluation, okay? And if your upper extremity are involved as well, they ought to be evaluated as well, okay? So this is part of doing a postural evaluation, and it's a necessary part. The posture evaluation looks like this. I look at how you look in the chair, wherever you are, how you are right now, I look. Then I take you out of the chair and I put you on a firm therapeutic mat, and I look. The difference is DPT students from yesterday. Ha! Come on, you guys. I gave you this exact slides. The difference between in the chair and on the mat is, in fact, the chair. Okay? So the chair is going to push your body into certain shapes. And part of that is the interaction of the mobility of your body and the configuration of the chair. That's what I'm seeing in this comparative eval, okay? Then I'm going to put you on the mat, and I'm going to lay you supine, and I'm going to look at the same basic markers. I'm not going to go through all the markers. They're basically shoulder height, sternum, pelvic, rotation, stuff like that. But you could look up the evaluation if you wanted to, but the point here is when I compare sitting to lying down, I'm looking at the effect of gravity. This tells me how well you can hold against gravity, and whether or not I'm getting some push and pull just from gravity, okay? What that means is if I can get you straight on the mat, if I can line you up and you look fabulous on the mat, my goal is fabulous in the chair. That's what that means. It means I have a flexible system and my goal is fabulous instead of some compromise, okay? If I put you on the mat, I straighten you up, and you look like this, my goal is not fabulous, my goal is the best I can do, okay? So that's what that evaluation is for. And then I'm going to do some flexibility stuff and some leg measurements. And again, yesterday I talked about if I have a leg length discrepancy in standing, right? I got one leg that's longer. I'm going to tend to have a little scoliosis that happens from it, right? Okay. If I'm sitting down, if I'm standing up, do I care whether I've got a longer femur or a longer tibia? Not really, right? But if I'm sitting down, do I care where my leg length problem is? Do I care whether it's longer at the upper leg or lower leg? Yes, because the chair configuration is going to be different depending on where that shortest is, okay? So you have to measure both. And then while they're out of the chair, I'm measuring the chair they came in with. Now some people go, but they're getting a new one. Why do you want to measure the one they're in? Because that's going to help me understand how they look, okay? And the measuring with a current chair helps me figure out why they're being pushed into a certain posture, etc. Okay, so wheelchair seating, doing seating right, in and of itself with nothing else attached, I want you to understand and believe it's therapy. It's therapeutic, okay? Now, it's not the only thing you ever have to do, but without it, you're missing a key component to people who have to use a wheelchair every day. It's their only form of mobility. So full-time wheelchair users, this is absolutely an essential part of that. Okay, so here's a picture to prove it, okay? So again, this gentleman has C8, and I'm showing you him before I worked with him on seating. He was a good 17 years post his injury, I'm pretty sure, okay? This is not a one-day. Some of my photos are like the same day, just reconfiguring the same equipment. This is actually new equipment, a different chair. But I didn't do any other therapy, okay? This is not me doing any stretching. This is nobody cutting anything and doing a Z-plastic. This is just working with his current body and matching it and adjusting it and improving his seating. And you can tell that this improved his balance, okay? It decreased his neck pain, his back pain, his shoulder pain, and I will tell you, it made him look a whole lot better, right? Including it looks like he lost weight. He did not lose weight, okay? And he looks a lot better. And I would also say that vanity is a good thing. We should be encouraging people to want to look better. We should be encouraging people to not have urine bags hanging out. It is part of our job to help the expectation be, yeah, you should want to look good. You should be a little bit offended if I'm suggesting you wear sweats for the rest of your life. Yeah, okay? Now, if you like to wear sweats, okay, you can battle back. But if that's not what you used to wear, then my goal, rehab, right? Back to what you want. Okay, so seating intervention is sometimes and too often buying new equipments and backrests and putting new stuff on a chair. That is too often a seating intervention. What it ought to be is taking a look at this, the wheelchair configuration, okay? And a whole bunch of people think seating is like some sort of specialty guru science, and I'd love you to believe that because it's me, but it's really not. It's intro PT. It's basic goniometry, linear measurement, applied anatomy, and a little bit of using your brain. I will admit, there's a moment or two where you have to dig out geometry, but other than that, it's really not hard. It's matching angles. Okay, so what it basically means is instead of getting some sort of piece of equipment that's in a certain size and stuffing your patient into it, you make sure that you measure the patient, know their needs, and then get the equipment that fits them instead of the other way around. There are some critical leg measurements. This is why I say you have to get out of the chair and at least have your lower body evaluated, okay? So it's the hip range of motion, okay? But it's not just flexion and extension. It's also rotation, okay? Think for just a minute. Most wheelchairs are made of metal, though the good ones are carbon fiber now, but mostly metal, and they're mostly symmetric, right? So if I have, say a rotation deformity, where maybe my leg's like this and I don't have internal rotation to neutral, if I then put that foot down on the footrest that is symmetric, up goes the pelvis, right? I am creating a pelvic obliquity. If I have an intact vestibular system, I'm creating multiplane scoliosis, right? Vestibular system will drive eyes horizontal and vertical, and everything between will align to make that happen. Okay? Okay, now, this is another rule. Always intervene in the sagittal plane first. This is the sagittal plane, okay? Well, actually this, okay? Sagittal plane is where you need to start. Can anybody, where's the handsome guy from Hazard? There you go. about the spine. Good. And it's about the curvature of the spine. That is good. All right, you got the easy stuff. Anybody? Yeah. Good, 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 good. So you can see the head and the anterior posterior tilt, but the reason you have to start there is because if you're in an anterior tilt, your spine is what about the facet joints? Closed pack, okay? So now your spine is closed pack, which means it's kind of working like a rigid lever, okay? Whereas when you're in a posterior tilt and spinal flexion, got a lot of slop, technical term, slop between every vertebrae, okay? And whatever you do in the frontal plane, this one will be too much if you correct the sagittal plane second. Everybody follow that? Super important point. If you don't remember why, then just remember the rule, okay? And it's okay to do that. The upper extremity is obligatory. The upper extremity biomechanics are obligatory to the spine, okay? So you cannot have ideal upper extremity push mechanics in a crappy seated posture. Impossible, okay? You cannot know and look at range of motion at the shoulder without thinking about the spinal posture. Every orthopedic only brain out here ought to know that, right? Because you ought to be knowing that, for instance, reach comes from the thoracic spine in ranges, so you know that. So this is part of seating too. So if somebody comes in with shoulder pain, you can't just work on push mechanics. You have to start on posture. Okay. Right. So then I give you a frontal plane problem. Look at that. Because every time we look at somebody in a chair, we go, oh, frontal plane. It jumps right out at you. You should see it. But look over here. I give you a hint. These are conflicts. Can you see something over here, maybe right there, that jumps out at you? Maybe this difference. Okay? So his thigh length is shorter than the part he's sitting on. So what does that mean must be happening at the pelvis? Posterior tilt. If you posterior tilt your pelvis, what must be happening at the spine? Spinal flexion, right? Okay, good. So those are the concepts you need. It's like one follows the other. Okay, now, because of that, you look at this, where do you think I'm intervening? At these conflicts, okay? The second one is about hamstring tightness and the footrest place. We already talked about, you pull your feet forward with hamstrings that are tight, forward goes your butt, which is defined as posterior pelvic tilt, right? Okay? So, this is rearranging his current equipment, not purchasing a thing, just wrench work, okay? And notice the frontal plane problems go away, okay? And I didn't touch them. I fixed the sagittal plane, all right? There you go. Now, this young man had traumatic brain injury. He'd been injured for a number of years. And after I had seen him proceeding, he went and visited his mother, who he hadn't seen in about 10 years. She lived on the East Coast. She thought he'd had some sort of significant cognitive therapy because he looked so much less disabled. Posture matters. Your presentation matters. How you look to the world matters. Okay, now this one, I hope you can see well enough. But, so this is another gentleman with traumatic brain injury a long time. He'd been injured at 17, okay? But this is how he presented. His mom at this point in time was 74. When he fell out of the chair, which was becoming a chronic, almost weekly problem, they had to call 911 and the fire department had to come. He was sliding out of the chair. He was breaking footrests. He had had new footrests put on that were welded with steel reinforced side things, okay? And he was still breaking them, okay? So, what do you think? First off, look at his posture. I mean, what do you think? Does he have a lot of tone? You think no? I think actually yes. I think he actually has a lot of high extensor tone, okay? And I think he was probably pushing on those footrests with extensor toe. Why? Why would you push? Why would you push on your, if you were to, what is he maybe trying to do? Get back up, right? Particularly because he's aware that the fire department comes when he ends up on the floor, right? So he's pushing to try to get his seat back in. But one of the things that you may or may not know yet, because I don't know where you're in the program, but when you have aberrant tone, oftentimes once you trigger it, it gives you an all or none sort of exaggerated response. So sometimes you wanted a little push and you end up in a surfboard, okay? So that's kind of what was happening with that. All right. Notice this welded angle of the chair. That's a 90-degree welded chair, okay? So that basically means his hips should flex to 90 degrees, okay? Traumatic brain injury has a not uncommon secondary complication of heterotopic ossification, okay? Does that sound familiar to anybody? Heterotopic ossification often happens in the anterior side of flexor joints, so hips. So he only had 60 degrees of hip flexion available. So if you can only flex to 60 degrees at your hip, how was he fitting in a 90-degree position? Uncomfortably by 30 degrees of posterior pelvic tilt or spine flexion, right? Flexed spine is noxious. It's uncomfortable. If I asked all of you to sit the rest of the lecture in a posterior tilt with spinal flexion, you wouldn't be able to do it, okay? So the thing is, it was noxious. What do you know about upper motor neuron conditions and a noxious stimulus? It increases your tone, right? Okay? So the thing is, this is what we did. We adjusted his chair, and what I actually did now, I followed for 2 years. He didn't fall out of the chair for 2 years, so fine. And I haven't seen him since. I don't know what he's doing. But this is what we did. We reverse wedged the seat so that we only had a 60-degree, a little less actually than 60 degrees of hip flexion necessary. And then we rotated the chair in space so that he wouldn't slide out of that, okay? Now, the more important thing that I want you to know is his chart said globally aphasic. His mother said, no, he can communicate. I think he can tell me some stuff. And I know exactly when, at least when he's unhappy, I know. He looked at me right in the eye and he said, you're smart. Now I tell you that because obviously I am, but also because look how many years he had been determined to be aphasic. And what he was dysarthric because of a horrible position and the tone disallowing him to communicate. Okay? I mean, come on, people. If you don't think seating is therapy, I'm hoping that these little cases will help you start to see how important it is and how much you know about it already. You know about this stuff. You just have to apply it. Okay, so this is my slide that says this. Okay, so tone. Anytime we have discomfort, and in your spinal cord injured population, they may not perceive it in their head, but that doesn't mean noxious stimulus is not being driven to the system. You know that because of AT, okay? So if you're in an uncomfortable position, it's going to drive increased tone. Increased tone it can mess up your motor control, including speech. And effort. The harder I try, the more fatigued I am, the more my tone can go up too. So all of these things end up cycling and cascading, and then you have this nightmare. So whenever you see anybody who has any upper motor neuron syndrome, and they have any tone issues, you need to be looking at seating and push mechanics as part of the intervention for tone, okay? Before you're like going backward and other stuff like that, you need to look at the things that we know mechanically drive this stuff. Okay, so again, posture matters. It matters if I can't hold my head up and look at people. It matters if I don't have eye contact, if I can't produce speech, and if I can't control saliva because I'm in a bad posture. Very few of you, even though you're health professionals, would stop and start a conversation on the street with somebody who was drooling. I know you're all thinking, well, that's not me, but it's true. It's true. You really would, okay? If we can get somebody to not be drooling by a postural change, we're doing a huge, huge social intervention as well as other things, okay? All right, so what are we doing? We're harnessing gravity, okay? When you have a weak trunk, if you can't hold against gravity, you need to basically get gravity above the pivot point of the lumbar spine, okay? So you're going to put it in the front. This is why we tilt the chair, okay? This is the tilt. This is not the slope, this is the tilt part, which is why anybody who tells you that I can do it in a cushion is wrong. You can do a fair amount of slope in a cushion, but you can't do the tilt. You can't capture gravity by a cushion. That's literally by mechanically moving somebody in space so their upper body is going to be hit. And it doesn't have to be very much, 1 to 3 degrees, depending on how small the person is, in order to let gravity cause a pivot point. This is a picture of a computer schematic of the same concept I'm talking about, but in the left one, they left the seat back. The backrest is actually reclined 5 degrees, okay? And you notice that you end up with spinal flexion. You close the backrest, so this is where I'm telling you, vertical backrest, low and vertical, you end up with a much better alignment of the spine. The backrest controls the pelvis. As a wheel orthosis, the backrest is controlling the pelvis. The pelvis is the top of the hip joint, okay? So you can think you're controlling hip extension, if that helps your brain, or you're controlling posterior pelvic tilt. The anterior pelvic tilt is controlled mechanically by a bony block, by the slope. You can recreate that in a cushion, not the tilt, okay? So this is basically a quick schematic of what it really kind of ought to look like to stabilize the pelvis. And slope, for those of you who are still not quite sure what the heck I mean. A lot of people will say the chair is dumped or raked or whatever. But slope, I use slope because this is your geometry. It is a ratio. It's an equation. You have to divide, and the denominator matters. So it's the difference between the front of the seat to the floor, rear of the seat to the floor, divided by the distance between where you measured it, okay? And a lot of times the manufacturers change what it is. So you can do it across the seat depth or you can do it across the frame. But you've got to be careful. If you don't have the denominator and you decide you're going to reorder somebody's chair exactly like the one they've got, and it shows up different, that's why. Because denominators matter, okay? And then this is from my early work, and I actually gave Pat the publication. This is a 2003 Archives article where we basically showed that for a paralyzed trunk starting at a 0.25, which is basically 4-inch difference over 16-inch seat depth, which is 14 degrees roughly, okay? So that is what you need for a paralyzed trunk. But if you don't have a paralyzed trunk, it's a highly uncomfortable place to sit, okay? It's like stuffing somebody into too tight of shoes. So don't do that. If they are an amputee or they have an intact trunk, they don't need a system set up for paralysis. It's an important distinction. Okay, now, I just said 14 degrees. Okay, you guys good at your goniometry? Put your arm up at a 14-degree angle. Use your forearm and your elbow. Come on, you can do this. What do you think? Well, start with 0. And if you can't do it, you're like 0. Okay, 45. Keep splitting it in half. Okay? So what do you think? It sounds kind of steep, actually. Most of you are a little either too steep or too flat. Okay, so, oh, there we go. Okay, so if the person can't transfer because they can't move forward on the seat, you're going to have to compromise. So this is, again, for new injury particular, where they haven't learned transfer skills. My recommendation is you set up a different chair to teach transfers out of, or, in the really old school way, you give them the great chair that they should be in, set up for pushing. Remember I said, you're setting up for, maybe I didn't say it today, you're setting the wheelchair up to push correctly. The posture you want is for good push mechanics, okay? That means they might have to change position a little to calf or change their shirt or something like that, okay? But you want them for good push mechanics. Well, that's this angle. If they can't transfer, you can't interfere with function to have better posture for pushing, right? So maybe you have to compromise a little bit. What I do is I get the chair perfect, and I did a 3-ring binder, and I stick it under the low end, so that I basically have a flat cushion while I'm transfer training. As the transfers get better, the wedge goes away, I don't have a problem with it, okay? So then I can just take it out. Does that make sense for those who are kind of quickly following me? Okay. Also, if you're working acutely, and the person really is incomplete, and they really are changing, as they get more trunk innervation and strength, they need less slope. So that means you need an adjustable chair. If you get an adjustable chair, to adjust the slope height, you have to have an adjustable axle, adjustable casters, adjustable backrest, and center of gravity. Ah, it's a lot. I gave you the order to adjust it in. And I'm going to talk quickly about how you make those correct, okay? So, how the heck do I start? Start by ideal push mechanics. So set your rear seat to floor for push mechanics. How do you know what's best? Clinical judgment. You don't have to go with any one specific number, but what you want is a smooth arc stroke. You don't want extremes of range at your shoulder or your elbow or your wrist. Okay? That's the easiest way instead of remembering what to measure from. It's easiest to just use your clinical skills and look at joint range of motion. Okay? Then, after you set the rear for push mechanics, you set the front for slope, okay? And then you have to correct the caster housings so that they're vertical. And this is a picture of a vertical caster housing. Always check for verticality when the casters are in trail. Trail is where they would be if you're pushing the chair, okay? That matters because a lot of times when people are having trouble starting to move a chair, it's because the casters aren't aligned. Hospital-based chairs, demo chairs, student chairs are generally always out of alignment, okay? Because a lot of people use them and they use them incorrectly and they bend them a bit, okay? But if this is not vertical and you're having a hard time getting going, it's probably because the caster stem is pitched forward. If, on the other hand, somebody falls out of the chair when they're reaching forward, it's pitched back, okay? So these are just something to check. I'm into troubleshooting, and this is a troubleshooting thing, okay? Also, if somebody comes in, they got a floating caster. If they have a floating caster, you're thinking, that's not seating. Yeah, seating in wheelchairs go together. So if they have a floating caster and a rigid chair and a rigid footrest basket, loosen both sides of the footrest before you do anything else. Because most likely somebody torqued the footrest when they were adjusting it, and that rigid frame torqued a little bit, and you could do all kinds of work, and all you have to do is loosen the footrest, okay? Footrests, they come down in a V like this. The foot plate actually is bolted onto 2 pieces. They're separate. And again, if somebody adjusted the height and didn't loosen the foot plate, they've torqued the chair and the frame's going to be torqued and nothing's going to be running there, okay? And that might even be why somebody's back seems to be rotated now. Because if you torque the frame, you're going to torque the backrest, and one height's going to get higher, etc. Okay? So again, look for the simple stuff first, and that on any chairs that are used by multiple users, anything that's adjustable, loosen and adjust appropriately, and a lot of your problems will go away. Okay? The backrest should be vertical or very close. Okay? But if they're vertical, they have to be low. So a vertical backrest needs to be a T10 or lower. Okay? So keep that in mind. And that's with the cushion in place. The center of gravity, if you have to go higher, if your backrest is higher, fade it away, loosen the top straps, that kind of thing. Okay? Your center of gravity, good for balancing. Okay. All right, quickly, too big is worse for posture. Too little is only bad for skin. Okay? So, too big is worse for posture. So I would much rather have a too little chair. I'd rather have a growing chair end up too little than start too big, okay? Because posture matters so much, okay? Too wide is a big problem because I can end up with my pelvis shifted, and then I'm going to end up with scoliosis, okay? And then the backrest angle is big, meaning obtuse. You're into all the nightmares we talked about. And I'm getting my almost signal. Okay, all right. Okay, fine, here we go. If somebody is complaining about pain in their chair and getting back into bed or getting out of the chair helps it, you need to assume it's posturally related, okay? Headaches, neck pain, upper thoracic pain, shoulder discomfort, all are related to posture, okay? If they look like a C from the side, C from the side, okay? If they look like that, it's deathly, okay? It might be a cute cuddle, but it's a horrible way to sit in the chair all day, and particularly if you're pushing, okay? So, what is that going to look like? Forward ahead. You'll have a fold right here. There's a fold right there, a more protuberant stomach, okay? Shortened height if you're measuring them, and a longer length and space sagittally. You can also get these indications. Somebody's really having to hold themselves up for conversation, or they feel like they're going to fall forward and they ask you to pull their legs forward in the chair. Those are all signs that the chair is set up incorrectly. Okay? This one's a hard one for people. Stable to do two-hand work away from the body. If somebody's set up for really good postural alignment for wheelchair propulsion, and they have a paralyzed trunk, they lose the privilege of work away from the body with both hands. They're paralyzed. They can't do this. They ought to be able to do this, like two hands if they need to adjust something close to face. Should have that stability, but around here they should not. As soon as you reach away, you should have to stabilize with one hand. You should teach like this, okay? If they can reach away, they're stable, they're in a posterior tilt, and that's a deathly way to sit all day. Now, that doesn't mean it's not functional, which means you should teach people to pull the butt forward like that when they need two hands, but then they should know how to pull right back into good posture and know that it's a transient position. Okay, basically, if they're flexible, put a lumbar support in, and you're good. If the backrest is reclined, get it out of recline, add a lumbar support, particularly if the backrest is tall. This is what it should look like. This is a weak C5 individual, C5 on one side and one C4, okay? Last two things, if they're going up an incline and they're always unable to keep their casters down and they're tipping over backwards, the first thing to look at is in the backrest recline. Because in the backrest recline, it's going to make it really hard to go up ramps. But if you close the backrest angle, you need to improve that, okay? And then it might be a wheelbase, which is the same advantage. All right, those I don't need to do. You want me to do them? There's three. All right, when do I need a cushion? So this is a question that comes to me whenever I talk to people that have users in. Now, obviously, you need a new cushion if you got skin breakdown. If you have skin breakdown, you go to a provider and you get a good evaluation. Okay. But if you're living in the community and you think, when should I get a new cushion? Well, when you should get a new cushion is when it's got obvious signs of age, okay? Well, how do I know that? This is the most important thing. Take a picture of your cushion when it comes out of the box, okay? When you live with something every day, you stop knowing what it's supposed to look like, okay? And you're like, you see it and you're like, well, that's all wrong. It's like higher than mine and everything else. So and the other thing is, they'll lose height and they'll gain weight. And either of those things mean that cushion is dead, okay? And you can still live on the same cushion that you used to have. I am a firm believer, if you have equipment that works for you, get the new one. Get the same thing. Don't listen to people who want to sell you whistles and bells, because almost always the thing that's been working for you is what you actually in fact need. So that's what I do. But there you go, okay. All right, my wrap-up slide is, look, hopefully I've convinced you that seating is health promotive and preventive. So we're preventing a lot of problems, we're making people feel better, they're going to get out into the world. It's only really especially when it's indicated seating. Indicated seating is more like when a person's already jammed up, they got a lot of problems, maybe some skin breakdown. Then you really do need to refer to somebody who's done it for a few more years. But my hope is that you are comfortable enough, you see someone who doesn't look good in their chair, that you'll jump in. You'll do the eval, you see what you can do, and then if you absolutely think you need an expert, here's how to find them. And the bottom one is you can always send me an email. But if you send me an email, I'm going to send you back homework. It's like, okay, that's great. Now you got to do these measurements for me and send me these photos, and I'll be happy to help you out. Okay? All right, there you go. Ta-da, ta-da, ta-da. Boom.